He was a morbidly obese surgeon destined for an operating table and an early death. Now he's a rebel MD who is fabulously fit and fighting to make America healthy again. This is Stay Off My Operating Table with Dr. Philip Ovadia.
Welcome to Stay Off My Operating Table with Dr. Philip Ovadia. Our guest today is Kim Mischo, who's got a different, it's exactly in our wheelhouse and also completely outside of our wheelhouse. It's fascinating. So without further ado, Phil, why don't you tell us why Kim is on our show?
Yeah, so we're going to be talking about cardiac imaging today. That's Kim's area of expertise and focus. And like you said, it's interesting that among the many ways that I have started to recognize deficiencies in the way that we take care of cardiac disease in the healthcare system, imaging is one of the very interesting areas that has come up and has developed. And so there's a lot of very exciting things that are going on. And that's why I had gotten connected with Kim and said, we got to talk about this on the podcast because it has been an interest of mine within the practice, how we start to leverage these tools and what role they play. And we'll talk a little bit about why they aren't playing maybe as big a role as I think they should be. But before we get to all that, I'm going to give Kim a chance to give her background, talk about why and how she got interested and involved in cardiac imaging, and then we'll go from there.
Perfect. Thank you for having me, first of all. So yeah, my background is actually, ironically, nuclear medicine. And later on in the podcast, we'll get to the irony. I'm sure Dr. Ovadia knows the irony behind this, but my background is nuclear cardiology specifically. I started my medical career as a nuclear technologist working in cardiology, and then went on to be a healthcare administrator within both independently owned cardiology practices, and then it graduated to big healthcare system cardiology. So about 20 years of experience specifically in cardiology.
Great. And I'm not sure I would say that going to the big system cardiology was actually graduating or a step up. It might be a step backwards in some regards, but we'll get into all of that as well.
For sure.
Yeah, it's interesting in the heart disease world, right? That let's just talk about generally the role that imaging has played traditionally, and maybe we can make some contra distinctions against things like the cancer world, for instance, where there might be some parallels, but cardiology has developed in a separate way. But yeah, let's just talk about the general. First of all, what are we even talking about? What is cardiac imaging? And then what are some of the tools that have been used historically? And maybe we'll get into then what are some of the newer tools that we now have available to us when it comes to cardiac imaging.
Perfect. So yeah, I'll speak to historically. The most prominently used tools or imaging was stress echo, just plain echo, or stress nuclear testing. And the thing that I've identified over the course of my career, and 20 years ago when we started this, we didn't realize how much disease we were missing in the nuclear cardiology and in the stress space. Essentially, you have to literally be almost on the verge of a heart attack to get a positive nuclear stress test. And I'm not saying that there's no place for nuclear stress testing. There certainly is in patients that we need to look more at function that have later stages of heart disease. But as far as early diagnosis of coronary disease, not a good test. We had many patients. We did 15 nuclear stress tests a day at the facility that I worked at. And we had many patients during that time I was there that we told, you have a negative study, and they went on the next week to have a heart attack. Some of them dying, some of them surviving it after telling them a week prior that their study was normal. So we move forward and we look at the guideline. Oh, sorry. Did you have something to say, Jeff?
I don't know. I'm just the Phil said it, where stuff is broken, but the idea that you could walk in, get a nuclear stress test, which by the way, I don't actually know what that is, and then be given a clean bill of health, and then literally the next week end up with a heart attack. I mean,
Yes.
it's
Yeah,
absurd. It's
it's
absurd.
absurd as it seems to Jack, and it should be as absurd to everyone else. I just want to go back a second here and level set, right, to help people understand the problem that we're trying to solve, right? When you have a heart attack, that's generally fairly obvious, right? And the medical system has a pretty good system for taking care of you when you have a heart attack. However, identifying who is truly at risk of having a heart attack, who is on their way to a heart attack, and giving an opportunity to intervene before it gets to that end point, we do a very lousy job of in the medical system, in medicine, right? And some of it is just around limitations that we had in tools. But again, the focus largely, when we look at heart disease broadly, right, the main advances that have been made in the heart disease space have been around taking care of people that get advanced heart disease and keeping them alive longer. But
Right.
we still do a very lousy job of saying, this is someone that is on their way to advanced heart disease, and let's give an opportunity to intervene and not let it move forward. So with that as a sort of context, let's talk about some of the tools. So you mentioned nuclear stress testing. Just give the brief what that actually is and what the problems have been with it, what the limitations are.
Sure. With the nuclear stress test, patients come in, we put an IV in. Essentially, we take an image of their heart at rest. Then we put them on a treadmill. And while they're on the treadmill, if they're capable of walking on a treadmill, there is such a thing as a chemical stress test. But most patients would walk on a treadmill. When we got them to peak exertion, we would inject a radioisotope that would basically go into their bloodstream and go as deep into the heart wall muscle as the blood goes. And so if there was a deficiency of blood in a portion of the muscle of the heart, essentially it wouldn't light up because that radio tracer wouldn't go there. And so a patient would have to essentially have a blockage that was reducing blood flow to the point, that's why I said almost need to be on the verge of a heart attack before that study is going to show up positive. So then you put them back on the scanner after you've injected the isotope, and we look at how deep, and we compare how deep did the isotope go into the heart tissue at stress versus rest, and that's it. And you really have to have probably a narrowing of 90% or greater to have, or we'll say 80%, I'll be generous, but 80% or greater to have that reduction in blood flow. But with coronary CT angiography, we can tell if a patient has 5% blockage instead of waiting to image a patient until they have 85%. And many of those patients were symptomatic, right? So we're trying to figure out if their chest pain is really going to lead to a heart attack, or if it's some other, that they're having chest pain for another reason. So yeah, and I think it's important to point out that back in the day when I was doing 15 of those a day, those were being reimbursed at roughly $6,000 a study. So that's pretty good. I know it doesn't compare to the OR, but it shouldn't compare to the OR. There's not as many costs associated with that. And so, but comparatively, CT angiography is seeing a reimbursement rate of $350. So we can diagnose disease at 5% blockage with it. The guidelines changed in 2021. This isn't new technology. This has been around, and the guidelines said in 2021, this should be the first test for early diagnosis of coronary artery disease. So why are we not doing it? There are several reasons. I just mentioned, I mentioned loosely reimbursement. That's one of the barriers. So I'll pause.
And again, to make it clear what we're talking about here, right? We have many tests in the cancer world that are designed to detect cancer at its earliest stages, right? Mammograms, colonoscopy, screening for lung cancer with CT scans, right? All of these things are designed because the thinking in cancer world is the earlier we diagnose the cancer, the better chance we have of saving that patient's life and improving all the outcomes associated with it. In heart disease world, this really hasn't been the thinking, right? The thinking is maybe we're going to do some blood work that may or may not actually have anything to do with heart disease. And then when the patient gets advanced heart disease, when they have symptoms, when they have a heart attack, right? That's when we're going to deal with their heart disease. And that gap in between of, okay, figuring out how can we figure out who is really at risk of heart disease, who is developing heart disease, and maybe we can then do something to stop it along the way, has been a huge gap. And honestly, it was a technology gap to start with, right? We didn't
Yes.
have a good way of imaging the arteries without an invasive test, right? So we have what's called cardiac catheterization. That's been the mainstay. That's been around 50 years now. And so you can do an invasive test where you actually put a catheter up a patient's arteries, go into the heart, essentially, or right near the heart to be technical, and you put dye directly into these coronary arteries that we're worried may be blocked, and you can see the blockages. But that's an invasive test. It involves risk. It's not something you want to undertake just if you're screening people, essentially, right? They or may not have
Absolutely.
So
Absolutely.
before we get to CT angiography, let's talk about coronary artery calcium scanning, something we've mentioned a lot on this program, something I talk a lot about. That was really the first test that could give us a sense, non-invasively, of who might have significant disease developing.
Yep. So at our center, we actually do calcium scoring as well as CT angiography, and I can explain why, but I definitely would like to explain that with calcium scoring, essentially, we're only looking at disease that's calcified. That's not the most vulnerable plaque in the vessels. A calcified plaque usually is adhered to the vessel wall or inside the vessel wall, less likely to break off with a change in blood pressure, where the soft plaque is really the risk. And we don't see soft plaque on a calcium score. It's in my opinion that a calcium score is better than nothing for certain, but we've imaged patients at our center who have come in for a calcium score who had a score of 5, and they're like, so I'm good, right? Because my friend had a score of 200 and he was good, or my friend had a score of 200 and he got a cath, so my score of 5 must be fine. And we have to explain to patients, we don't know, because we don't know if you have 80% soft plaque and 10% calcified plaque, or 80% calcified plaque and 10% soft plaque. So we really can't give you, all we can tell you is, yes, you have coronary artery disease at this point.
I've never even heard the phrase soft plaque or hard plaque for that matter. I've just thought plaque was plaque.
That's because, to Dr. Ovadia's point, we've not been able to image it or see it before more recent technology. And I'll say the technology that we're talking about is a high-end CT scanner that can acquire the whole heart in less than a second. And so it minimizes the motion in the picture as well. And so hospital scanners aren't built for that. You can image, their CT scanners generally can acquire the whole heart over 6 seconds. So imagine how much that heart has moved in 6 seconds. And then the computer's filling in that data instead of it actually being true and accurate data. And so if we can acquire the whole heart in a quarter of a second, this is your highest end CT scanners that can do that. It's not generally what hospitals buy. Because quite frankly, and I was a hospital administrator in radiology, we can bill the same CPT codes off of a low-end $1 million scanner as we can off of a high-end $2 million scanner. And so there's no motivation for the healthcare systems to buy the high-end scanner to do cardiac imaging. So then a lot of cardiologists—
Other than preventing heart attacks, but hey.
Yeah, I missed that one. Yeah, I missed that one. Sorry.
That one gets dropped a lot, unfortunately, in these discussions. Okay. Yeah, I just want to, like I said, so people are keeping up with what we're talking about. Coronary calcium scanning, that really came, mid-90s, early to mid-90s is when the technology developed. Because, like you said, so we had a technical challenge, right? The heart is always moving, and taking pictures of it becomes difficult. So that is one of the limiting things when it comes to, okay, we're trying to get pictures of the heart and the damn thing keeps moving. So we had calcium scans at first, and like you said, crude, but at least gives us some idea about who might be at risk, who's not at risk. You have a 0 score, great. Who's more at risk, and some relative, but it's not a perfect scan because we're getting incomplete pictures of what's going on within the arteries of the heart. So
Correct.
then CT angiography comes along, and let's talk about just from a patient perspective, right? So they come to your center, they get a coronary calcium scan, has been ordered by their doctor, what that technique actually is, what they'll go through. And then if instead their doctor has ordered a CT angiogram, the differences, just again, so people understand what we're talking about here.
Sure. So yeah, CT calcium score is super simple. Patients are in and out of here in 15 minutes, generally speaking. They don't need an IV. We don't need heart rate control. They essentially come in, we ask them some medical questions so that the physician has it for their report, put them on the scanner, acquire the image. Like I said, they're in and out usually in 15 to 20 minutes. With CT angiography, it's super important to control heart rate. So patients are here a variable amount of time. We tell patients to allow for an hour and a half when they come in. Our target heart rate for acquiring a CT angiogram, again, we want to slow down the heart rate so we have less motion. So if a patient comes in at 85, we want to get that heart rate down to 60 so that in that quarter of a second when we're acquiring the heart, again, there's half as much motion. And that makes a difference for the readers. And so we will reduce the heart rate to 60 beats per minute by giving patients metoprolol, IV metoprolol, oral metoprolol, diltiazem. We have a variety of protocols that we use to reduce heart rate. And by the way, all of our protocols were derived from the Lundquist Institute at UCLA, where Matt Budoff sits. And Matt Budoff and Tony DeFrance are my two readers that are here as well. And so they demand that heart rate control because this is not an easy study to read. And so if we can make sure that our protocols make for better image quality, it's going to make their read more accurate. And of course, being the world leaders in the reading space, they want their reports to be accurate. So heart rate control, we put a patient in, we give the patient an IV. When they get to the scanner, we get the heart rate down to 60 beats per minute. We give the patient a tablet of nitroglycerin, and that vasodilates the vessels. Again, we're taking a vessel and maybe taking it from 1 to 2 millimeters and increasing the size of it. Again, that's really for the reader so that they can see the vessel and they have something larger to look at. And so it's all about image quality, what the protocols are. And so the image itself takes a quarter of a second. Patients on the scanner, generally speaking, for 5 minutes. We get them laying down, and then they get contrast for this study so we can better visualize inside the arteries the same type of contrast that you give in the cath lab.
Yeah, so again, this gets to if you just do pictures without administering contrast, right? You can see calcium in the blood vessel,
right?
But
correct.
You can't see non-calcified, this soft plaque that we're concerned about. So we give this dye through an IV, and that now allows us to see the greater detail within that blood vessel. And we can see both the non-calcified and the calcified plaque. And so this technology has been evolving over the past, we'll call it 20 years or so. The scanners get better. So one of the things you mentioned is how fast the scanners can get the pictures. And if you're trying to get a picture over 2 seconds, you're going to get a lot more motion than if you're getting it over a quarter second. So that's been one of the real technological developments. And with that, you also get better resolution, right? Just like people went from watching their old cathode tube television that was all grainy, and now we have 4K and 8K and whatever high def things that we're at. The pictures look a lot different. And it's the same thing when you're looking at the output that comes from these CAT scan machines.
So yeah, the accuracy when CT angiography is done on a single beat scanner, high speed scanner, the accuracy is 99%. And so occasionally I would hear cardiologists tell me, I would love to order CT angiography, but every time I do, our image quality is crap. And then we end up going and ordering a nuclear stress test. That's it for one of two reasons. Either they don't have the technology to acquire a good quality image, or they're not controlling heart rate. They don't have great protocols for it. So it's one of those two things, because really, when it's done on the right equipment, it's 99% accurate. There's no other imaging, no other stress test, no other predictor of heart disease that's 99% accurate.
Great. And I think one more step that's going to be important for people to understand, and then we can talk about how the test gets used and why it might get used in certain ways and why it's not being used in certain ways. But the latest development in this scanning, the latest sort of technological development is, again, if you go back 10, 15 years, a patient comes in, they get this scan, and a radiologist who's a doctor trained to look at scans, or cardiologists who have gotten that training, extra training now in interpreting the pictures that come out of these scans, they would sit in front of a computer and they would look at the pictures and they would interpret how much blockage there is, what types of plaque there is. But it ended up being a sort of, we didn't have that high fidelity in these interpretations. We would get something like a common statement that I would see as the surgeon now trying to figure out how much blockage this patient has, right? I would be reading a CT angiogram report, and it might say that in a certain blood vessel, there is a mix of soft and calcified plaque, and there's a blockage that is in the, let's call it 50 to 70% range is a common thing that I would see. And then I'm sitting there wondering, is it 50%, which I might not be that worried about, or is it 70%, which I'm going to be worried about? And you didn't know. We were guessing.
Right.
The newest technology that has come along related to CT angiography is now, at first we called it kind of computer-aided analysis, and now we call it AI analysis. So talk about what layer that now adds to these scans.
Absolutely. So if a patient comes in and they get a positive scan, let's just say it shows they have 30% blockage on their CT angiogram, and that's the point at which we make the recommendation that they get an AI plaque analysis so that they get more information. We've already identified that the patient has disease, but let's find out, what is the plaque mixture? Where exactly is the lesion? Does the lesion look like it's mostly soft plaque, or is it stable plaque? Is it about to rupture? Is it in a location that's higher risk, more proximal in the heart, or more distal in the heart? We get so much information from these AI analysis that essentially the patient doesn't even have to come back to the center at that point. We call the patient, we say, we've identified that you have coronary artery disease, and we offer the plaque analysis. Now, there's one additional step. If a patient gets a plaque analysis, and let's just say it shows that it's in a very vulnerable location, there's a lesion that has a lot of soft plaque, we want to know, is there a reduction in blood flow? Does this patient need to go to the cath lab? And so there's something called FFR, or ischemia testing, where it can take a measurement of what the blood flow is above the lesion and below the lesion. And this is all, of course, via AI, which I know you can do that in the cath lab as well with a wire. This is obviously non-invasive, as I mentioned. And so we can get a measure. We can tell, does this patient need to go to the cath lab? And I can confidently say, when I say that this is 99% accurate, we've sent hundreds of patients to the cath lab in the 2 years that we've been open here. And I have a good relationship with the physicians who take care of these patients that go to the cath lab. We have no business relationship together. They're totally independent of us. And I think that's important to note. But I ask them, if ever we get a study that we send you that does not correlate when you get in the cath lab, i.e., we sent a patient to the cath lab that doesn't need to be there. If that ever happens, please let us know. And before I got on this podcast today, I called the owner of that practice to say, I just want to confirm that this has never happened. And he said, in 2 years, it's never happened. Every patient who we've sent to the cath lab was a patient who ended up getting a stent. So a patient that needed to be there. Conversely, 10 years ago, when I worked in cardiology, we were doing nuclear stress testing. 70% of patients who went to the cath lab then did not get a stent. So there's 70% of patients who went to the cath lab that did not need to be there. And so you ask yourself, that was 10 years ago, right? That was before we had access to good scanning. But why are we not utilizing this more if we can prevent all of those unnecessary procedures which, by the way, don't come without risk. Any invasive procedure comes with risk. And so I can speak pretty confidently to that 99% accuracy because we haven't got it wrong once yet.
Just from a math standpoint, never being wrong is actually 100%.
I know, but you can't ever say 100%.
But from a marketing standpoint, it's smart to
someday
leave
it'll
yourself
happen.
a little space there.
Yes.
And the flip side of Kim's point is, again, when we were relying on nuclear stress testing, we used to have a 10 or 20% at least miss rate, right? That the patient did actually have significant disease. The stress test was not abnormal. We think, okay, this patient's not at risk of a heart attack. And like Kim said, a week, 2 weeks, a month later, they have a heart attack. And with this technology, we're not missing that either. We're seeing all of the patients that actually have real disease. We're making sure they get appropriately dealt with. And we're not underdiagnosing or overdiagnosing, right? Which are both problems with other testing in medicine. All right, so now we have this great test. It can show us early stages of heart disease. Okay, this should be like mammograms for women, right? You should go get it every year starting at a certain age, and everyone should know about this test and should be doing this test. Not true is the answer. So let's talk about why isn't this test being used more? What are some of the barriers and what are some of the challenges around this testing? From why aren't doctors talking to their patients more about it, and why aren't patients getting it done more?
Okay. Yeah, so I'll start first with insurance. That's our favorite subject, right? So insurance isn't covering it. So this is the test that diagnoses coronary artery disease. And I'm slowing down as I'm saying this because I want this to really sink in. This is the test that diagnoses coronary artery disease the earliest, but you have to have a diagnosis of coronary artery disease in order for your insurance to pay for this scan.
Oh, brilliant.
So when you think about the economics of that, and my brain is very in tune to economics, the insurance companies don't want to diagnose coronary artery disease early because 60% of patients, between 50 and 60% of patients, die from their first heart attack. That's an insurance company's dream patient, right? They never paid for a claim correlating to coronary artery disease and the patient dies. So if we start screening everybody, 50 or 60% of those patients that went on to not cost the insurance company $1 because they died, they will now have to pay for.
My God.
So they're not covering it. Insurance companies don't want to cover it because it opens Pandora's box, right? You get that diagnosis and all of a sudden you have access to the medication you need. Essentially, you never pay for a coronary CT angiogram again in your life. That's really what my business model was all about. We need to create an affordable self-pay option so we can crack that door open to get people the diagnosis that they need so that they can get the coverage that they need. So yes, it hurts a little bit on that first one. You have to pay roughly $1,000 to get a good quality. And there are facilities out there that will do it for $400 or $500. And we talked about the differences in technology. It's not just the accuracy of the test that is the downfall of old technology. It's also radiation exposure, which I know, Dr. Ovadia, you and I talked about on our first conference call together. And I think even you were surprised to know that with these very up-to-date scanners, patients are getting 1 to 2 millisieverts of exposure. That's roughly the same that they get from a calcium score when it's done on a high-quality scanner. My husband had his first CT angiogram on a 128 slice scanner, and he got 19 millisieverts. And I know the millisieverts part, that's not important, right? But 1 to 2 versus 19, you're talking.
We are talking radiation here.
We're talking radiation, 15 times as much exposure. And by the way, on my husband's report, it said poor image quality. And you don't pay less for poor image quality, right? So yeah, we set out to design a self-pay model so we could open the door for people to get their first CT angiogram as a screening tool and then determine essentially if a patient comes back totally clean, statistically, they have less than a 1% chance of having a coronary event in the next 10 years. No mammogram or colonoscopy gives you 10 years. So patients that come back completely clean, we say come back in 5 years. You're good. You're good for 5 years. Come back in 5 years, because we don't want to wait too long, because we want to find the patient when they have under 50% blockage, because then as a provider, they can go after that aggressively with aggressive treatment and therapy or dietary changes. There's a plethora of tools that they can use to stop the progression of that disease. But if we don't have a baseline study, we don't know how fast a patient's disease progresses. That's different in every patient, right? So one patient might get 10%, an increase of 10% blockage over 5 years, where the next person might increase 10% in their level of stenosis or narrowing in 1 year. And so you have to have a baseline study in order to diagnose early, so your provider, your doctor, whether it's primary care or cardiology. I'm putting a lot of faith in the primary care community here, not because I have anything against cardiologists, but I say if you have a cardiologist in America today, you probably already have advanced heart disease. So we need to work with the primary care providers so that patient doesn't go on to ever needing a stent or ever needing bypass. It's possible.
Most people think the most dangerous room in your house is the bathroom, where you might slip and fall. But after decades of repairing hearts, I know the real crime scene is actually your kitchen table. It's where the slow motion heart attacks begin, one meal at a time. You've read my bestseller, Stay Off My Operating Table, and you know my mission. But now I'm going to the source. In my new book, Stay Off My Kitchen Table, we expose the metabolic evidence hiding in plain sight in your own pantry. Stop being a patient in waiting. Head to Amazon right now to pre-order Stay Off My Kitchen Table. Your heart and your future self will thank you. Yeah, and it's obviously something I'm passionate about, and I scratch my head. Yes, there are insurance barriers and cost barriers, and yes, there's a radiation concern, which again, that issue is getting to be less and less of a concern as the technology gets better and better. But there really is a philosophical deficit in the world of cardiac disease management, of that we should even be making an effort to diagnose disease at early stages, right? And I know this sounds unbelievable, and Jack's shaking his head for those of you that are listening and not watching, but the concept of we should be making the effort to diagnose heart disease at its earliest stages is still a very foreign concept within the cardiology disease world.
Yeah, and you mentioned earlier, if you flip the coin there and we put that into the oncology world, if we told a patient, you know what, you have cancer, but we're going to wait 10 years to treat it. Nobody would say that, right? We know what the outcome would be. We know the outcome would be far worse. It's no different with coronary disease. We tell somebody that they have low-level coronary disease, you have the genetic predisposition, either that or you have poor diet, you have poor lifestyle choices, you have whatever the cause is, but at least you know you have disease and you can work on treating it now.
Yeah, that's really what this gets to, right? And again, as I have my interactions with the traditional cardiology world, right, we might argue about, okay, what is the best way to prevent disease from getting worse once we figure it out? But we shouldn't be arguing about, let's just figure out who has disease and who doesn't. And again, and this is going a little bit off topic, but, we've been sold the bill of goods in heart disease world that your blood tests, and specifically your cholesterol levels, can really tell you have disease or not. And the reality is nothing could be further from the truth. So one of the other things that kind of gets in my brain as to why aren't we using this testing more is that it would unveil things like what we discussed as we're recording this. We had just released an episode with Nick Norwitz, right? And he has a LDL cholesterol level that is astronomically high, and he's got no plaque in his arteries. And we're seeing more and more examples of things like this, right? That if you do start to correlate the traditional blood work risk factors with what is actually happening in the arteries, we're going to quickly see that there really is not great correlation there. And that whole blood marker centric management of heart disease is going to fall apart pretty quickly. And I think that's really one of the other barriers that's preventing this from being used more often.
Absolutely. Yeah. And I'll go back to the cancer correlation once again. If we flip it the other way and we say, if we were to tell a patient, we already talked about that, sorry, that you have cancer, we're going to wait to treat that cancer till later, that would never fly. So sorry, I lost my train of thought there.
No. Just about the time I think I can no longer be surprised by the utter anti-health behavior of the air quotes healthcare community, something like this comes up. I'm still trying to get over, they don't want early diagnosis because they'll die so they don't have to pay the healthcare costs. Having slightly vented my bile there just a little bit, the next question becomes, you got to be actually in the machine to get this scan. This is not something you can do over Zoom. You're located in a suburb of
Loveland,
Denver,
Colorado.
I believe.
Yes, Loveland, Colorado, just north of Denver.
Where else in the country do people go for these things?
So that's the barrier. There is not an option for self-pay. There are other places people can go to get a CT angiogram, but if patients want to do this as a screening tool and they don't have the diagnosis, they need a self-pay option. If you go to the hospital, like my husband did for his first CT angiogram, we paid over $3,000 for it. That's a barrier. Not that many people can nor will. Why was I willing to? Because I worked in cardiology, because his dad had a heart attack at a young age, because I wanted to invest in our healthcare, et cetera, et cetera. But that's not affordable for most people, right? And that's on the low end, honestly. So $3,000 for a poor quality study on top of that. So yeah, the self-pay is the important thing. So when you ask where else can you do this, right now, we're the only independently owned non-hospital, non-radiology group that does self-pay CT angiography on a single beat scanner. There are other imaging centers that do it. But if you want accurate, and we have patients flying in to Colorado every week from out of state, from out of the country, they're doing their research. People can find, we know that, right? And they research. I had a patient who came in here who had read the manual on my scanner before he came.
Lord.
Yeah.
Guessing
I
he was
haven't
an
read
engineer.
the manual on my
Was that one of my patients? Because, we have a few like that in the practice. But
yeah.
Oh, wow.
Yeah,
So,
no, I mean, and again, I can speak to this challenge, right? Because having a nationwide telemedicine practice like I do, we have patients all over the country, right? And so we say, great, we want to get a scan. Where do we go for it, right? And my team oftentimes is going through, it's not the phone book anymore, but the internet equivalent of the phone book, and calling around to different imaging centers wherever that patient may live and say, do you do this scan? If you do, how much will it cost them? They want to pay, they're going to be paying out of pocket. That is oftentimes, you can't get an answer, or it's very difficult to get that answer because they're not used to that. And then the quality issue is another one that is very difficult to figure out. You have to really get into what kind of scanner do you have? What's your technology? And then, okay, now we want to layer on this AI analysis. That becomes a whole nother figuring that out. So having a place like you now have had the vision to set up, if we had these available widely everywhere, that would get rid of a lot of the barriers to getting this testing done now for patients.
Yeah, and we are working on expanding. We have centers that will be opening, additional centers in Colorado. We have a center that'll be opening in Wisconsin. We have a center that'll be opening in Texas now and Tennessee. So it's just spotty. It's really, where are there doctors that really want access to this? And people are reaching out to me or whatever, by whatever means, but they want to start a practice. But we talked about the challenges with reimbursement, right? At $350, how do I do this and not lose money? Because we know it's beneficial to the patient. We know it prevents unnecessary procedures, but how do I do it and not lose money doing it? And so that's what I set out to do. I actually took a non-compete leave for 1 year from the healthcare system that I worked for. And for that year, decided to go into the sales world. And so I sold this scanner, actually, that's sitting behind me, a single beat scanner. And for that year and a half that I was out talking to cardiologists all over the western half of the US, I heard the same message all the time. I want to be able to do CT angiography, quality CT angiography, but I don't know if I can make money doing it. And then it really became, not only can I make money, because if you're not making any money, then it's not viable. You have to be able to make money. It doesn't have to be a gross amount of money. But the difference between $6,000 for a subpar nuclear stress test for early detection and $350, there's a delta there, right? And so there's organizations like the Society of Cardiac CT. We're all working together to try to get that reimbursement up so that we see higher utilization, but it still doesn't allow access to the patients who want to do it for screening. Because again, if you don't have chest pain or you don't have that right diagnosis, we need access to self-pay so patients can get the screening and diagnose early.
Yeah, the insurance and reimbursement aspect of this is a very real problem because, like you said, if you're running an imaging center, like you said, and you can get paid, you can promote one test that you're going to get paid 20x. The other test, obviously, you're going to be promoting that test just from a business standpoint. And that's where we need the government level interventions and the insurance companies to start realizing the value of this test. And a lot of work to be done there. And in the meantime,
absolutely,
being able to offer it at an affordable cash pay price is another way to go about this. And thankfully, you're making some efforts on that front, but we need to see that spread as well, so more patients have access to that.
And people ask me all the time, so if you knew you weren't going to make a lot of money doing this, why would you do it? And I think the answer to that is twofold. First of all, this test saved my husband's life. He had this test done the day before he had the test done. He had it done as a screening tool. I mentioned that. We paid $3,000 to get a crappy scan. The day before the scan, he hiked 22 miles at above 10,000 feet with 75 pounds on his back.
Good Lord.
He had no chest pain. He didn't go and have the scan done because he couldn't do it. I couldn't keep up with him. Nobody can keep up with him. He's very physically fit, totally asymptomatic. He did it because he had a family history. He did it as a screening tool and to be proactive. But we literally caught him on the verge of a heart attack with 90% plus blockages, multivessel disease, extensive disease at the age of 50. So if he had this scan done at the age of 40, we would have known that he had coronary artery disease. And of course, there's more than just statins. There's more. We have PCSK9 inhibitors. We have dietary changes. We have all the things that doctors can throw at this to treat the disease. But nobody's going to pay $4,000 a month for Repatha, for a PCSK9 inhibitor, and your insurance is not going to give it to you if you haven't already tried a statin and proved that it didn't work. And oh, by the way, my husband was on a statin for 5 years proactively because of his family history.
Yeah, that's a whole nother bucket of worms.
Yes. And we see plenty of patients, and I get asked that question all the time. So do you believe? And it doesn't matter what I believe. I'm not a physician, first of all. I don't pretend to be one. It doesn't matter because, again, if we diagnose the disease early, people and providers can do whatever they want to try to treat that disease and get scanned a year or two later and know if what they're doing is working.
Yeah.
Whereas in the statin world before, like my husband, we prescribed it 5 years prior. 5 years went by. Nobody said, oh, I wonder if that's working. maybe we should go in and look to see if the disease is, if first of all, if he even has disease, right? We throw statins at people. Again, that would be like giving people chemotherapy proactively because their mom had breast cancer. We wouldn't do that. So why do we do that with heart disease?
Yeah, this is another very important aspect of this, right? Because it's not only about making the initial diagnosis, it's then about following the progression, right? Because again, we can argue, and of course, I spend a lot of time arguing what the best way to manage this is. But ultimately, today, we don't really have a good way of following over time, is what we're doing working or not working when it comes to heart disease. Now we have a tool that we can do that, right? Because if you can do this scan with low radiation and low cost, great. Now I can get that scan on you every couple of years. And whatever it is that I've recommended to you, whether it be a pharmaceutical or it be a lifestyle intervention or some voodoo witch medicine, right? I can now evaluate 2 years later. Is your disease worse or is it better or is it the same? And if it's the same or if it's better, great. Keep doing what we're doing. If it's worse, we got to change course. We got to figure out something else to do. And that's where I really think the major advancements in heart disease are actually going to come from. They're not going to come from putting patients on medicine blindly and hoping it works out and discovering that it didn't work out when it's already too late. We're going to be able to really evaluate what works and what doesn't work before people have the major problems.
Yep. I do want to go back to the economics briefly, because I think this is another really important piece. In that year and a half that I was out talking to cardiologists across the western half of the US, and they would all agree that they wanted to be able to do CT angiography. The other common statement I heard is that the healthcare system doesn't want me to do this yet. We're going to wait. We have our nuclear equipment. It's paid for. We're going to continue to do nuclear stress testing. If I could tell you how many times I heard that, and they would say straight up, the reimbursement isn't as good. We're going to lose money if we do that. And I would say, you're certainly not going to lose money. You have to think of the downstream benefit. If I'm a healthcare system, and today 70% of my patients are going to the cath lab and don't get a stent, that's roughly a $6,000, $7,000, $8,000 diagnostic cath. But then you flip that, and 100% of patients who go to the cath lab actually need a stent, 1 or 2 or 3 stents. That's a $10,000 or $20,000 or $30,000 procedure. The economics of it would work itself out if we would do what's right, and if we could get the healthcare systems to not put revenue ahead of patient care, or patient outcomes, I should say.
Yeah, patient outcomes.
And it's not doctors. I want to be very clear. I worked for a lot of my cardiologists, and I'm friends with many of them still today. It's not doctors not wanting to do right by their patients. Doctors got into healthcare because they wanted to help people. Exactly. It's not that at all. It's being part of a system. And frankly, we watched it. I started in cardiology when it was an independent practice, worked there, then they were consumed by the healthcare system. And now many of these people would do anything to get out of that system and go back to the way it was before. Yep. And I do think we're going to see that over the next decade, the unraveling, because I think we're losing doctors at far too fast of a pace. Their job satisfaction is poor. They aren't practicing medicine the way that they want. They don't have the autonomy that they want. So I think we'll see it unravel, but it's not going to happen overnight.
Wow. Like I said, this is right smack in the middle of our wheelhouse, and also really way outside it. It's a cool, thanks, Phil. This is really good. Kim, tell folks where they can get more information about what you do. Granted,
absolutely,
there's not a lot of places where this is an option, but hey, at least there's one.
And you have to start somewhere, right?
Gotta start somewhere.
I picked Loveland, Colorado, A, because it was close to my home, but B, because it wasn't a major metropolitan area. And I wanted to prove that through my business model, we could make this work financially in the top 30% of cities in America instead of the top 2%. And I've made it work. I was profitable at 4 months into business. So we've made it work. And I do think we'll see this expansion go pretty quickly. It's almost not a day goes by that I don't have somebody reaching out to me saying, I want to put a clear heart in my practice. I want to, and again, they have a cath lab, they have the interventional piece. They want to fine tune that too. There's so many people that need care, so many people waiting a month or 2 months to get into a cardiologist. These cardiologists want to be seeing the patients that need them, not the ones that can be taken care of by their primary care providers. So I do think the expansion will happen more quickly than we think, but unfortunately, at a rate of 600,000 deaths a year, it won't be fast enough for a lot of people.
Yeah. So the website is?
Yes, clearheartandlung.com. So you can go to clearheartandlung.com. We're always changing the website. We're posting where we're opening new locations. We're actually going on the road this summer. We have a mobile RV that has the same scanner in it as this one, and we'll be hitting the road and going across Arizona into Texas to Louisiana and then into Florida. And so we're going to go out and find people that need scans, and we're going to save one life at a time.
That's amazing. I took a quick look at your website. Okay, a little more than quick. And one of the things I noticed is that there's multiple sets of scans.
Yes.
Clear, comprehensive package, CT scan, plaque analysis, calcium score, lung screening, bone mineral density, just a whole bunch of stuff.
Yes.
I don't want to open up an entirely new direction here that would probably be better with another podcast, but maybe giving a quick overview of what all those other things are doing?
Absolutely. Yes. We tried to design packages that would work for every type of patient. So there's some patients, many patients that are sent to us from their preventative care doctors. They want to know, do I have 5% stenosis? And if I do, I want to make this change and that change. They want to get scanned in a year to check to see if that's changed. And then you have people that just want to know, am I going to have a heart attack this year? Or am I going to have a heart attack in the next couple of years? And so we try to figure out through conversations with patients, what is it that they hope to get from this? And so that's how we help tailor that. The pieces like the bone mineral density, we'll be offering epicardial fat analysis very soon. All of these additional tests like the bone mineral density, the AI plaque analysis, the AI ischemia, those are all tests that are derived from the data from the scan. And I'm very passionate, my background being nuclear medicine, about keeping exposure low. So if a patient's going to be on the scanner and they need a bone mineral density, or they were going to go get one next week, get one now, because we just pull the data from the spine, which is behind the heart. We're not giving them any more radiation exposure. And so that's where some of those add-ons. And then lung cancer, obviously being a cancer that happens pretty prevalently, we felt like that was another really important screening piece.
Very good. All right.
And one more thing about
Sure.
the comprehensive package. Oftentimes people will come in just to get the plaque analysis and the CT angiogram, and then they'll say, okay, I want to understand this better. And so we have doctors. Dr. DeFrance does most of our concierge consults with patients, not to become their doctor, but simply to help them interpret the results that they got. Especially he and Dr. Budoff both read all of my studies, and so they've worked together at some capacity for over 30 years. They know each other's work. And so it gives patients the opportunity to get a really in-depth dive into their results. And that's part of the comprehensive package.
Phil, I love how you keep coming up with these things that, A, I don't think you can surprise me, and then you do. And then B, really expand the options for folks to do a better job taking care of their own health. So,
Yeah, that's really what this is all about, patient empowerment and being more proactive, taking back control of your health like we talk about all the time. I want to thank Kim for coming on. I knew this would be a fascinating conversation. I think the audience will really learn a lot from it. And we are hopeful that this becomes more commonplace. But in the meantime, people can empower themselves to go get this done. And it's a great way to figure out where you really stand regarding your risk for heart disease.
our
Absolutely.
guest Thank you, Kim. Our guest has been, did I pronounce that right?
You
I
did
didn't
when you
ask.
introduced me, Mischo. Thank you.
Kim,
Yep.
our
Mm-hmm.
guest has been Kim Mischo of Clear Heart and Lung. You can find out more about this scanner and scanning and what they do at clearheartandlung.com. So for Dr. Philip Ovadia, this has been Stay Off My Operating Table. We appreciate y'all being with us, and we'll talk to you next time.
Chances are you wouldn't be listening to this podcast if you didn't need to change your life and get healthier. So take action right now. Book a call with Dr. Ovadia's team. One small step in the right direction is all it takes to get started. Contact us at ifixhearts.com/talk. That's ifixhearts.com/talk.